My name is Leslie Busby, and today I'm presenting on Sister Callista Roy and her Roy adaptation model. I found Sister Callista Roy and her adaptation model both interesting. She advocates preparing the next generation and having them learn and build on her model. She dedicated her life to the future of nursing, and she still, at her age now, is working on her model and adapting and working on future nurses. In an interview that she was in last year, Sister Roy stated that she was most proud of that her best accomplishment is yet to come. She continues to work, which started in her early 20s, and as the need has risen, she has responded and adapted the model to more current ways of thinking. Her ideas have grown throughout the years and been very helpful in nursing. The Roy adaptation model is very significant to nursing. It became the framework for nursing practice. It's commonly used in nursing practice still today, and the basis of the theory is to improve practice. It includes a mandate for research and education. It has influenced how we think about nursing. Sister Callista Roy was born October 14, 1939 in Los Angeles. She grew up in Los Angeles in a large family. She was the second oldest of 14. There were 7 girls and 7 boys. In having that large family, she said she learned to share and to help, and that she learned many life examples and life experiences. Her mother was an LVN, and throughout her childhood, she learned a lot about adaptation, changing situations, and figuring out new ways of doing things. Sister Roy has an extensive list of degrees. She started her education back in 1963 when she earned her baccalaureate degree in nursing from Mount St. Mary's College. In 1966, she had went on to get her master's degree in nursing at UCLA. And then in 1973, she had went back for her sociology master's degree at UCLA. And finally, in 1977, she gained her doctorate in sociology at UCLA. She began her career in her early 20s, her first year out of undergrad school. She was an associate professor and chairperson of the Department of Nursing at Mount St. Mary's College until 1982. And in 1983, she was promoted to professor at Mount St. Mary's and at the University of Portland. From 1983 to 1985, she was a Robert Wood Johnson postdoctoral fellow at the University of California at San Francisco as a clinical nurse scholar in neuroscience. And then in 1987, she began as a nurse theorist at Boston College School of Nursing. Sister Callista Roy has had many publications throughout her life. She first developed the Roy adaptation model in 1964. It was first published in 1970 in Adaptation, a conceptual framework for nursing. And then in 1999, she developed the theory further in the Roy adaptation model. She's been published in many books, articles, and presented the concepts in many lectures. In the recent years, she has been more focused on contemporary movements in nursing knowledge development and spirituality. She has dedicated her life to caring and giving to others. She is a member of the Sisters of St. Joseph of Carondelet. She is a board member of the New England Center for Faith and Science. She's the Boston Theological Institute, which gave her opportunity to work with scientists from many fields. She's been a volunteer at the Women's Prison and the Catholic Chaplains Advisory Board of Framingham Women's Prison. This gave her the opportunity to study issues of crime, corrections, and justice, and to work with nurse scholars from many countries. In developing the adaptation model, Sister Roy had many influences and inspirations. She developed the model as a graduate student in 1964 when she was challenged by Dorothy Johnson to clearly define nursing. She was influenced by Johnson's commitment to describe the goal and the nature of nursing. She read a short paragraph of Harry Helson's adaptation theory. Immediately, she knew what nursing was. She said nursing is promoting patient adaptation. The model has been developed over many years. The Roy Adaptation Model Board has translated the theory into multiple languages, used creative ways to provide better resources, has developed the theory worldwide, has enveloped cultural adaptation, and has used global outreach. Sister Roy had stated in an interview that she had not found anything that needed to be dropped, but there were times that it did need to be developed. Different times, the different elements were the focus. Roy contributes the model's success to the fact that it came from practice and it was developed from patient behavior. She further defined the adaptation in 1999, stating the process and outcome whereby thinking and feeling persons as individuals or in groups use conscious awareness and choice to create human and environmental integration. The major concepts of the Roy Adaptation Model were as follows. The goal for nursing is to promote adaptation for the individual and groups in the 4 adaptive modes, thus contributing to health, quality of life, and dying with dignity by assessing behavior and factors that influence adaptive abilities and to enhance environmental factors. By manipulating the stimuli rather than the patient, the nurse enhances the interaction of the person with their environment, thereby promoting health. The adaptation model has 3 levels: integrated, compensatory, and comprised life processes. Integrated life processes may change the compensatory process, which attempts to reestablish adaptation. Inadequate compensatory processes can lead to compromised process result. Mechanisms for coping. Roy describes the coping processes that include both innate and acquired. Innate means they're genetically determined or common to the species. They're automatic processes, whereas acquired is a learned or developed through the responses. She describes 2 categories of processes for coping. The first is the regulator. It's an automatic, unconscious response to neurochemical and endocrine coping channels. The second is the cognator. Response to 4 cognitive emotional channels. Those channels are number 1, perceptual and information, selective attention, encoding, and memory are involved. The second one is learning. You have imitation, reinforcement, and insight involved. The third is judgment. This is your problem solving and decision making. And the fourth is defenses. You seek relief from anxiety and make effective appraisal. The cognator regulator and stabilizer innovator subsystems function to maintain integrated life processes. She states that behavior is either adaptive responses or ineffective responses. And then those responses serve as feedback to the system. The feedback is then used to decide to increase or decrease the efforts to cope with stimuli. Roy describes 4 categories of behavior in her model. It can be observed in 4 adaptive modes. Responses and interaction with the environment can be carried out and adaptation can be observed. The first one is physiologic physical mode. There are 5 basic needs: oxygenation, nutrition, elimination, activity and rest, and protection. The second is the self-concept group. The basic need is psychic and spiritual integrity. The third is role function mode. The basic need of this group is social integrity. And the fourth one is interdependence mode. The basic need is relational integrity. The model lists 3 classes of stimuli. The first is the focal stimulus, the object of the event most present in the consciousness. The second is the contextual stimuli. This is all the environmental factors that present to the human adaptive system, not the center of attention or energy. And the third is the residual stimuli. The effects may be unclear if there's no awareness of this one. Sister Roy's adaptation model discusses the 4 meta-paradigm concepts of nursing. The first one is person. She describes the main focus of nursing is the recipient of nursing care, an adaptive system with cognator and regulator subsystems acting to maintain adaptation in the 4 adaptive modes. For environment, She states it's understood as the world within and around humans as adaptive systems. All conditions and circumstances and influences surrounding and affecting the development and behavior of persons and groups. She describes health as a reflection of adaptation. It's a state and process of being and becoming integrated and whole that reflects person and environment mutually. She goes on to say that nursing is a healthcare profession that focuses on human life processes and patterns of people with a commitment to promote health and fulfill potential for individuals, families, groups, and the global society. Roy also used the model to develop her own 6-step nursing process that is used frequently in nursing today. The first step is to assess the behaviors manifested from the 4 adaptive modes. The second is to assess and categorize the stimuli for those behaviors. The third is to make a nursing diagnosis based on the person's adaptive state. The fourth is to set goals to promote adaptation. The fifth is to implement interventions aimed at managing stimuli to promote adaptation. And then the sixth is evaluate achievement of adaptive goals. For my example in practice to show the Roy adaptation model, I use the scenario of a 42-year-old male truck driver who has a left MCH stroke. He loses partial function of his right side of his body, has a significant visual field cut, a noted facial droop, and some difficulty with speech, and most importantly, he will no longer be able to drive a truck. So the first step in the 6-step nursing process is to assess the behaviors manifested from the 4 adaptive modes. For the physiologic and physical mode, the patient tires easily with activity due to the large size of the stroke. The self-concept group identity mode, the patient describes feeling unattractive with a severe facial droop and difficulty speaking. Role function mode, the patient describes feeling like a failure to his family as he is no longer able to provide an income for his family or help his wife transporting the children to and from school and activities. The fourth one, interdependence. The patient states he feels his wife and children will no longer lose respect for him as he feels as if his wife has another child to take care of. In the second step of the nursing process, we're going to assess and categorize the stimuli for those behaviors. The first one is the focal stimulus. The patient has had a large debilitating stroke. The second one is the contextual stimulus. Loss of full use of the right arm and leg, altered appearance, and speech difficulty. The third is residual stimuli. The inability to carry out the ADLs without assistant, inability to return to job and provide income for family, and alteration in role as the patriarch of the house and loss of independence. The third step of the nursing process is to make a nursing diagnosis based on the person's adaptive state. Impaired mobility related to right-sided weakness secondary to left MCS stroke. Activity intolerance related to muscle weakness secondary to stroke. Self-care deficit related to musculoskeletal impairment secondary to stroke. Risk for injury related to right hemiplegia secondary to stroke. Ineffective coping related to ongoing grieving and need for permanent change in lifestyle secondary to stroke. With those nursing diagnoses, we're going to set goals to promote adaptation. For impaired mobility, we're going to promote optimal level of function and prevent complications. For activity intolerance, we're going to manage activity within limits and decrease fatigue. With self-care deficit, we're going to provide support for immobility and other self-care activities to promote independence. Risk of injury, we're going to prevent injury. Ineffective coping, patient willingness to participate in treatment plan and utilize available support system and resources. The next step is to implement our interventions aimed at managing the stimuli to promote adaptation. So we're going to remind the patient to walk slowly, rest adequately between intervals of walking, use effective lighting, use assistive devices as appropriate for ambulation, use clothing with zippers, use suction cups on personal hygiene. Assist the patient with activities, identify energy-conserving techniques for ADLs, and we're going to assist the client to identify and utilize available support systems and provide information about resources and support groups that assist the client and significant others in adjusting to and coping with the effects of stroke, such as websites for the American Stroke Association or local support groups. The last step is we're going to evaluate the achievement of the adaptive goals. The patient noted to increase activity tolerance daily. The patient noted to be able to perform ADLs without assistance. Patient without injury. And patient speaking openly about concerns and anxiety, expressing eagerness to attend support groups. I felt there were many strengths of the Roy adaptation model. The basis of the model is to improve practice, which includes the mandate for research and education. It has influenced how we think about nursing, and it appeals directly to the bedside nurse. It's developed from practice, and it was further developed over the years to focus on contemporary movements in nursing knowledge, development, and spirituality. I also felt there were a few weaknesses to the model. The model is very long, it has multiple components, it's difficult to interpret all the components. You must read it multiple times to comprehend. And although the basic meaning has not changed, there have been several updates over the years, which adds even more to the concept. Thank you for listening to my presentation on Sister Callista Roy's adaptation model.